Hi, my name is Solomon Culver, and I'm a hospitalist at The Ohio State University. And this is the second of a series of lectures building up to our journal club on the paper Restrictive or Liberal Transfusion Strategy in Myocardial Infarction by JL Carson. This is a New England Journal article, and it is a great way to go over a lot of concepts and topics in evidence-based medicine. The topic of this lecture is subgroup analysis and heterogeneity of effect. And before we get started, I hope that you could please like and subscribe to help my channel out. So, technically, the results of a clinical trial can only be directly applied to patients who would have met the study inclusion criteria. Some studies have a lot of exclusion criteria, so that the patient population is molded and sculpted and gerrymandered until the end result is patients who don't resemble the ones that we actually see in our practice. And that sort of study is said to lack external validity. Because investigators want us to use the results of their trial, they are under a pressure to have minimal exclusion criteria so that their study population will match the patients that we actually see. In order to make efficient inferences, it's also important for investigators to recruit patients who are likely to have the same response to the treatment. If they recruit a very heterogeneous population with a lot of different subgroups, and some subgroups have improved outcomes and others have worse outcomes, then the end result of the study may not show any significance. When the trial population is very diverse, clinicians may also wonder if the benefits were equally spread out, or if they really only benefited one small subset of the group. Therefore, investigators are under a pressure to keep their study populations focused and homogeneous, and to have a lot of exclusion criteria to shape the population to have efficient outcomes. So there are pressures for both diverse study populations as well as focused ones. So how should we balance those? Well, diverse study populations consist of a collection of focused ones. So if we begin with a diverse real-world study group, then we can break it down into subgroups after the trial is done and to test those subgroups for different effects. But if we start with a very focused and potentially externally invalid population, then at the end of the trial, there's no way to statistically test for generalizability because that data was never collected. In order to show that the results of a study apply to the entire study population, many papers will break the population down into subgroups. And that subgroup analysis is meant to look at different homogeneous groups within the population and calculate a measure of effect for each one. Now, if some of the subgroups have a huge effect while others have a small effect, or even worse, a harmful effect, then we would describe the study as having heterogeneity of effect, and that creates a problem for interpretation. Now, these subgroup analyses may also include quote-unquote 95% confidence intervals, but these are not actually 95% confidence tests, and we should not interpret them as saying anything statistically valid about the subgroups themselves. At the end of the study, when the investigators do the subgroup analysis, if there is no effect heterogeneity, then we can just take the study results at face value. Now, if there is heterogeneity of effect in a study that was overall negative, meaning some subgroups appeared to have a response to treatment, then it's really not adequate for statistical inference because it's not a pre-specified test, but it could be a good reason to do a follow-up clinical trial that only looks at those promising subgroups. Now, if a study is positive overall, but in the subgroup analysis there's heterogeneity, and some subgroups have no effect or maybe even a suggestion of harm, then we have a dilemma. it's not clear how to apply those results. It could be reasonable to avoid treating patients in the subgroups that suggest harm, even though it's not statistically defensible. But it could also be reasonable to reject those subgroup analysis results as having any statistical meaning and apply the overall trial result, even in the patients with those potentially concerning subgroup analysis findings. So to summarize, clinical trials are under two completely opposite pressures. They're under a pressure to be inclusive in order to maintain external validity, but they're also under pressure to limit enrollment to narrowly defined populations so that we can avoid heterogeneity of effect. It's common to have an inclusive trial and then to evaluate for effect heterogeneity in the subgroup analysis. But this analysis is post hoc. It's meant to be qualitative and not quantitative, and it really shouldn't be interpreted as hypothesis testing. So depending on the results, we may be left in situations where it's hard to know how to apply them. The MINT trial was a study that compared increased red blood cell transfusion goals to standard goals in patients with acute MI. The study included patients with a variety of different types of myocardial infarction, including acute coronary syndrome, demand ischemia, and a couple types of stent thrombosis. The primary outcome of the study was death or myocardial infarction, and it had a relative risk of 1.16 with a confidence interval that included the point of no effect, which makes this overall a negative study. But even though it was a negative study overall, the point estimate for the primary outcome did suggest some benefit, even if the confidence intervals didn't make it quite statistically significant. In order to test for heterogeneity of effect, the authors did a subgroup analysis, which I have here pictured to the right. And as you can see, most of the subgroups have a similar magnitude and direction of effect. There was one subgroup that had a suggestion of harm, which was patients on dialysis at baseline. And that's reasonable, that's plausible that they would be harmed by increasing their transfusion goals. Now, there was also one population that seemed to have a larger than standard effect, or at least a tighter confidence interval around that measure of effect, and that's the group of patients with acute coronary syndrome. Now, the point estimate of this group was 1.32, and the 95%, quote-unquote 95% confidence interval did not include the point of no effect. Of course, I put the 95% confidence interval in quotes because this is really not a 95% confidence experiment. None of these were pre-specified or adjusted for multiplicity. So the most that we can do with those results is think about doing a second trial focused only on patients with acute coronary syndrome. So our final analysis of effect heterogeneity in the MINT trial is that 1, there was no statistically significant benefit with respect to the primary outcome, and 2, even though the subgroup analysis suggested that there was increased benefit in patients with ACS, this was a post hoc study. The results were not statistically valid at the 95% confidence level, and at best they can motivate future studies of transfusion goals in this specific group of acute coronary syndrome.